So first of all, thank you for having me here. I just want to say from the neuroimaging session, my wife will debate the idea that antisocial behavior decreases with age. I think she'll debate that. She'll also see the picture of the soccer player getting hit in the head and probably send me for some evaluation for my brain damage that happened when I was a youngster. So unlike most of the other talk speakers here, I am very clinically oriented, although I originally started out my life doing research on immunology. Some of the stuff that Dr. Amari talked about with atherosclerosis, I give talks in the dental school about that and periodontal disease. My talk today is on very clinical 3D imaging in dentistry. To show you how cutting edge I am, this picture was from last week. This is Breckenridge. That's my son in the middle in the white pants there. We decided to fly out there on a moment's notice because there was no snow in Vermont. So that doesn't stop a periodontist from finding snow. Just so you know what we're talking about, for those of you that don't know about implants, implants basically have two parts. You have the silver part, which is a metal screw, basically, similar to what you get at Home Depot in screws, but much more expensive. And then the top is a crown that we put on the tooth. The patient doesn't care about what's the implant. All they care about those crowns. So when I first got into this 30 years ago, we were doing our implant placements based on the bone. And then the restorative dentist would have to deal with where we put this implant, because the patient doesn't care about where the implant is. They care about the three-dimensionality of where that tooth is. And so I deal in a very three-dimensional world. Even though I place my implants with CT scans and all that, it's a three-dimensional world I'm in. It has to look good when it's done. Otherwise, people are not happy with us. So the first thing we were using CT scans for, and we've been using three-dimensional scanning since I began in the mid-90s. They were radiographs. We had these big view boxes, and we take CT scans, and we shove them up the CTs on the box, and we had these calipers that we would measure on these. It was crazy. And then we try to go from this measurement on a view box to the patient's mouth and figure out where the heck we were. So we were really using them to just look at the anatomy. So this is a digital panoramic. This is a two-dimensional X-ray. But some of the things we can look at are, you have the sinuses here in the green here, and the nerve, which you see it's outlined in red here, the nerve in the jaw. And it's on this side also. You can see in this patient, it happens to be a impacted molar that's impinging on the nerve. And that's also something we can really look a lot at. So what we need to know from when we go to put an implant is, where those anatomic structures are, which we can see from a 2D X-ray, not so accurate. If you notice on this panoramic, you see a really good picture of their spine here and all that, which means that this is a very compressed picture. So it's very inaccurate. These scans can be up to 30% off. Not something you want to hear as a patient, that I'm going to be putting a drill that's going 1,000 revolutions per minute in your jaw, and I have an X-ray that's 30% off. Just not something you want to hear when I'm getting near nerves and blood vessels. So we can kind of see that. We can see if, relatively speaking, we have a lot of bone, a little bone, but we can't see exactly how much. And we can kind of go with height. We cannot see width on this at all, and we cannot see quality of bone at all on this X-ray. So what guided implant surgery has brought us is that it's now prosthetically driven. Instead of putting the implant in and figuring out where the crown goes, we first figure out where the crown should be, and then we can place our implant, and the crown will tell me where I place the implant. It's very efficient and outcome-based, so we know exactly what our outcome is going to be before we begin this procedure, rather than trying to fiddle and create our outcome after the implants are already in place. And our surgical and restorative team can then collaborate, and we can reverse engineer things. My restorative team will look at our placement before I even place it remotely and say, yeah, that's good, or no, I need that crown differently placed, and we can try, and sometimes we can't. Sometimes the bone is the bone. We can't change it, but a lot of times we can alter our surgical approach based on where the restorative dentist, who may have never actually seen the patient, wants us to place that implant. And we have data sets as patient surface scans that are aligned with the 3-dimensional. So we have the 3-dimensional scan, this cone beam scan, and then we take a digital, like an image in their mouth, kind of like used to be a dental impression. And we marry those two things together through landmarks so we can know exactly where the tooth is, exactly where the gums are, recession, everything about what you're looking at, which at the end of the day is what's the critical part, is what you're going to look at. We know all of that before we go in and place these implants. So that's how we get from the before here to something after here that looks presentable, that's not jury-rigged. And so this is basically on the right here, you have the implant is on the bottom, you have a crown, and then we literally screw the crown right into the implant. We used to use a lot of cements when we didn't know where the implant was, and now we can design them so the screw channel of the implant comes out in the exact right place so we can screw it straight in. So we don't have to cement things in. It's more retrievable if something breaks. It's a much better system. And here on the left, you can see this is what we get from the CBCT, this cone beam scan. And then we overlay that, a digital scan of what the teeth look like. And so we create a guide looking like this, knowing that this bridge we're going to make is going to fit right into those implants we're putting in. And it takes a lot of the guesswork out of it. And it really was a game changer for us with these surgical stents. So just what we see in clinic, the top image, that's a digital image of their mouth with a scanner. Basically what you would, if you've been to the dentist, had an impression taken. That is the impression, but it gives us both the soft tissue and the hard tissue. You see we're replacing number 14 here. The tooth number 14 is what we're going to be replacing. You can see this is that first shot I showed you of a panoramic. This looks like a panoramic. It's actually not. This is a digital reconstruction. And so you see now the implant here, and we see the crown, and you see it here as well. You see this crown is exactly where we want it. We know that that's where we want this crown, and we see that the implant is directly under it. We even have, it's in green, and you see this line on the outside. That's a safety that shows us that it's in bone and on all sides. And the implant is in the middle, the screw kind of looking thing. So this, the software will tell us if we have the bone around the implant to look at. And so we placed our crown here. You can see on that top image, we've now placed our crown. And that orange thing now, so that's the screw channel that we can see that if we place image here, if we place our implant here, the screw channel is in the right orientation, that'll come out right in the middle of the fossa where we want the crown. So we know now that this is going to be a successful situation where the implant's going to be in the right place, the crown and the screw hole is going to come out, so we can really nicely place a crown on there in the end. And then we create this, which is, you see that gold piece there. So that's a sleeve that now we're going to begin to transition that so I can get a guide to now guide my hand in the surgical aspect of it. And we can actually remove everything so we can see exactly where the implant is in relation to the jaw. And this is what I get back that I see in my practice. So we have a guide here, that blue green thing is a guide for me, and you can see the teeth, so it will fit directly on the teeth. So I don't have to cut the tissue, I don't have to do anything. I know where it is. Sometimes we do open the gums, but if I trust the computer enough, I know that this is where we're gonna end up. And I have my drills that will go right into that pilot hole and drill right into the bone. And these are the drills. This is MIS system. We don't use this anymore in the school, but it gives you the idea. So this system, you see how each of those drills has the same top on it. This part fits right into that cylinder, and then this is the actual drill. So we just go right down here, and we start with the smallest drill, and we just keep widening it up to whatever size our implant is. These are the different colors of the different size implants, so we can go right along and line everything up. This is me. I'm associated with Jonathan in the Boy Scouts. I'm the leader of the Boy Scouts here. I'm also the National High Adventure Coordinator for Jewish Scouting. This is at 9,000 feet. The rock we're on happens to be called the Tooth of Time, so it's dental related. Out of the largest camp in the world, which is a Boy Scout camp out in New Mexico. That's 200 square miles. It's the largest camp by people and by size. All right, back to the not so fun stuff. So now something more complicated. So that's a run-of-the-mill type thing that I just showed you. One implant or two implants, they're very straightforward. So this is a newer technique where we have a patient that comes like this, where these are his teeth, and we're going to do what's called an all-on-6. What we're going to do is at the same day, we're going to remove all those teeth. We're going to adjust the bone, we're going to place the implants, and we're going to place a prosthesis all in one day. So we need to really know where exactly those implants are going to be and where the bone and the teeth are going to be. So what we do is we create in the lab technicians will create, so now these are the teeth where we want them. This is the ideal situation where we're going to end up with those teeth on the bottom left. And now we take those teeth and those yellow things you see sticking out, those are our implants, and you see them here in the jaw. So these are the implants we're planning on place. This is how they come out in those teeth that these are teeth that we've fabricated. And then, so this is what our teeth are going to look like. Those yellow things are this is where the implants are going to come out, and these are where they are in the jaw. And so now, how do we translate that to our clinic? So what we're going to do is we're going to make a first jig, and this is called stackable. So we make a first jig, and we have these 5 holes here, and these are the teeth. So this is going to sit on our teeth, and we're going to drill the holes into the bone. We are then going to take that jig off. We're going to put another jig on, and that's going to mount into 3 of those holes that we previously drilled. So now it's exactly matched. And now we're going to take out the teeth and we're going to remove the bone up to the level. This tells us where to cut the bone to. And then we're going to take a second jig and mount over that. And you see these are those same holes. These are those same 5 holes. So 3 of them is that first jig that I showed you that's still in there. And the other 2 are this new jig that now has the cylinders for me to place my implants into. So now I've related it to my implants, and I can now put my implants right in those spots, and now I know exactly where those implants are, exactly where the bone is, and exactly where the teeth are. And then once I put the implants in, we can then the same day screw this in. If for whatever reason that doesn't work, because sometimes it's not so easy, what we also can do is we'll leave the implants and we'll take that day what's called a pick scan. We'll take a new scan, and then we'll create a new, and within 24 to 48 hours, we'll have a new, more accurate bridge for that to go in. Should sometimes we need to change surgically, we think there's a good spot and the implant doesn't take, whatever. If that happens during surgery, we have a backup of 24 to 48 hours. We can get them a whole new set of teeth, and we'll bring them back in and put them in. And that's it. This is me. I'm a big proponent of the real 3D in the outdoors. This is actually in their Sfat, Israel, about 2 miles from the Lebanese border in January. This guy up here is a chaplain in the U.S. Army, and he's also a high adventure tour guide in northern Israel. Unfortunately, he hasn't been so busy lately. Yeah. This was actually the day after the first Hezbollah person was killed in Beirut. So I was hanging off the ledge. My wife, according to my GPS, thought I was at the airport, the Lebanon. It showed I was in the middle of the Lebanese airport in Beirut. If you look at my pictures from the 3 days I was up in the north, I toured the Lebanese airport in Beirut. I swam off the coast of Gaza, and I was in Cairo. So it looked like I really got around. So yeah, really important. I know we're talking about micro imaging and inside people's heads. I always tell my students it's real important to make sure you discover the real 3D outdoors. So thank you very much.
Thank you very much. Any questions at this point?
So that's really amazing in terms of what you can do with the cone beam technology and creating the mounts for the precision implants. So you can kind of computationally map where these things should be, but then you ultimately need to kind of do it by hand and actually do the surgery. then you can see the location of the implants if you do the CT again. Has it ever been assessed, like, what the margin of error is, for surgery? Like, because, you won't be able to, there's a human step in there. Like, how well do people actually
So-
map?
So that's a really interesting question. Placing implants is very, it's not as easy as it seems. Maybe it's not, maybe it doesn't seem so easy to you. Our dental students seem to think it's really easy. And yeah, there's surgical complications. There's risks involved. I mentioned before in that, in the session, in the panel discussion, that it's a big issue because, it's very easy to send somebody for a 3D, maybe you have one in your office, and send it to some lab, someplace, and some lab guy that you don't know makes this guide, and you don't know the errors that are put into this. And then the patient comes on the day of surgery and it's not correct. Do you know it's not correct? And I would surmise that most of our dental students coming out would not know that it's not correct. And what do you do with complications? I learned freehand, right? I learned without guides. Relative to what we do today, I basically did implants blindfolded. I mean, it's really crazy that by puncturing nerves, and I mean, we go into sinuses all the time. That's not as big of an issue. But yeah, there's a lot of error that can be introduced into it. Interestingly, so I started about 6 years ago, and I was hired based on the fact that we were saying that we would do 3D. We would do all our cases guided. I don't do guided as much in my private practice.